So, welcome everyone to the first of our RSS partnership seminars. It's really great to see everyone here. We might have a few latecomers arriving sort of halfway through because some of our colleagues are at knowledge mobilisation training at the moment. So yes, this is the first of our seminars, and the idea of these seminars is to be able to showcase some of the really interesting and innovative work that researchers and colleagues in our wider partnership are engaged in. And it's a real pleasure to introduce our very first partnership speaker, Dr. Zahid Asghar, who's director of the Lincoln Clinical Trials Unit. And Zahid's going to be talking to us about self-controlled case series study. So the format of the session will be that Zahid will speak for about 30 minutes or so. Is that what you're expecting, Zahid? Yeah, yes, and then we will open up for questions, comments, and discussion. It's a good way to be able to get to know people from across our partnership as well. So Zahid, I'll hand over to you. And just to, for any latecomers, we are recording the session, but we won't record Q&A. Over to you, Zahid.
Great. Thank you very much, and thank you everyone, those who could make it today. As Rebecca said, I'm gonna talk about the self-controlled case series, which is a study that I did about roughly 12 years ago, and actually I'm following it up with another study recently. So it's still kind of an ongoing work in this area.
You were muted, I think.
Oh, did you hear what I said earlier?
Just we heard your introduction saying that you're about to do some follow-up work, but then it all went quiet.
Okay, sorry, I don't know why you went there, but anyway, so just a summary of my seminar. I'm going to kind of put into context the self-controlled case series methodology by kind of talking about other observational research and how this SCCS kind of fits in quite nicely in there. And just a reminder that all of this research, observational research, or whatever sort of research we are doing, we aim to reduce bias and confounding. And no matter what type of research we actually do, the confounding and biases of different types kind of creep in, and no matter how well you design your studies. So that these are the kind of things we try to eliminate. And so one of the best or the most common sort of studies is the sort of nested case control studies. These are kind of done all over the world, and I'm going to talk about them as well, and then compare the costs of different studies compared to the self-case control studies, how they actually compare and how it all fares with that, and what are the advantages of just looking at cases only design. And then I will end with sharing a published example, which I think should be on the also Becky's put it on the chats, I think. So
oh, you've gone quiet again, Zahid.
Sorry, I've moved to the next slide. It's just every time I move forward, my mic. Hold on, I'll minimize that. Okay. So the observational research types, I'm just mentioning kind of 4 different, just because of our time constraints, but the common ones, which everyone here, the RSS knows about, are actually the naturalistic type of the social science, psychological, psychology or behavioral type of observations, where we try not to in such a way as to be interfere with the participants, i.e. try to devise an experiment or approach where we can collect the data without actually interfering too much. And these are very complex studies. So over the years, people have devised many methods and approaches, and you know, we try our best, but there's always some sort of biases in there, historical recall bias, or the way the participants are chosen. You know, there's many things that come into these confounding variables. And then we have the specific cohort design case controlled observations where we have a data set which is already collected, routinely collected data sets such as the GPs or the ambulance services or others. And then we specifically collect a cohort that we're actually within that data set that we're interested in. And then we basically devise a methodology of case control and different statistical methodology to tackle that. And then the actual gold standard of it all is the clinical trials, where we actually try to repeat some of these experiments in real life. And so the costs of it all just shoot up because we are now doing real randomization, recruiting participants from multi-sites, and making sure that the data we collect is up to standard, and it fulfills all the integrity and the governance and the protocols that which we have set. So these take a long time to develop, but that, hence is the gold standard and where everybody tries to get to if they can get the budget for it. So in terms of the bias and confounding, it's very data time consuming, and it takes a long time into actually designing the study. So when we try to eliminate recall bias or minimize our influence or standardize the data, it always involves in actually exploring the environment we're collecting the data from. So what here at RSS and what I do outside the clinical trials in terms of normal research is we try to do our best in terms of standardizing all the variables we have. Do those variables contain any kind of erroneous information which shouldn't be in there, and how much of that data is actually missing, and things like that. So we try to reduce our subjectivity in this and try and follow our protocols as close as possible. And then when we do think, okay, there is some confounding here or there are some biases, so what's the best approach? So we say, well, actually, if we could match these individuals, so we have a matched case control study, then that would reduce some of the confounding. So we say, well, actually, we need participants, a particular age group, particular gender, or all genders, or we need people with certain age groups in there as well, from different ethnicities, different socioeconomic backgrounds. And so as you can see, the more things you start adding up, the more costly it gets. So the costs start adding up as well. But we do this all the time. In the more variables we can have to match against each other, then we say, well, actually, we're doing a good job here because we are trying to eliminate bias as much as possible. But there's always a danger of missing something. Okay, so that happens with some studies where people, no matter how long they've spent, spending a long time over design and research, they could actually forget the interacting variables. So I've just got an example here of coffee drinking and lung cancer. And so coffee drinking could cause lung cancer, but you'd think so. But if you forgot to add smoking in there, you would end up with a kind of false conclusion. So that was just to kind of highlight the different bias and confounding in not just the self-control case series studies, but in general. This is in general. So and so just as I've talked about the case control nested studies, and so what we do here is we restrict the population to our cohort, and we make sure it's more or less a cross-sectional longitudinal study. So in other words, we try to randomize in terms of who we pick. So everyone within this cross-sectional study has an equal probability of being selected. And so that's another way of saying that actually it's fair. And then we restrict on the conditions I mentioned before, age, gender, and other things we're interested in. So it could be people who've had strokes or who have particular cancers and things like that. So then we match the cases and controls. So as you can see, the prescription here is quite logical, and it's actually time consuming and costly. So, these are the things we have to do to make sure that the study that we are doing is actually worth itself in gold. And then all studies actually suffer from inclusions, different types of inclusion that we think are right, but actually end up being, say, we include a false positive in there. So we think that person actually had a particular disease, but actually it turned out it didn't. So that's a type 1 error. So we try to reduce that. And then there are false negatives. So, we think, well, this person hasn't got the disease, but in actual fact, they have, but they've been included wrongly. So these are the two types of errors which, as statisticians, we're fully aware of, and we try to put them into statistics when calculating sample sizes and what have you. But I thought I'll mention that because that's quite important in terms of when we calculate the large sample size and we do the matching. In this slide, I've talked about 1 to 2 matching, but in reality, there's 1 to 10 in some cases, depending how large your data set is. And so we try to avoid, false positives, i.e. get the alphas less than 0.05, and then case control studies are epitomize this, and this is what we use. And actually, the cost is nowadays it's around £100,000, depending on the sample size, but roughly they're quite costly. My PhD student got 1,000 elderly patients from CPRD for £10,000, and I thought that was expensive, and that was only two to 3 years ago. So it is costly, and we have to bear that into mind. And so this is where I think cases only is fabulous and comes in. The cases only design, because they're relatively cheap, and the sample size doesn't have to be massive. Instead of, say, 20,000, we're looking at 3,000 or 4,000 people. So it's much reduced sample size, and it lends itself really well to rare disease events, such as strokes, cardiovascular events, and it's also been used for vaccination and things like that. I'll talk about that later. So the biggest advantage here is we're only using cases as opposed to controls. So you'd ask, oh, well, that's interesting. Why cases only? Okay, because this is, on first sight would be quite mind-boggling, but just hear me out and I'll explain why this actually works. So actually, I've used an example. I've just made this example up earlier, and it's a fictitious flooring example where you have two types of floors. You have a slippery floor and a non-slippery floor, and what the actual exposure here is actually the different types of floors. So you could be walking on a slippery floor one day, and then jump across to the non-slippery floor, and then we basically take a diary of this, and over a period of a few years, and then you see the number of falls a person has had, and so this might sound like a trivial fictitious example, but actually it shows you these are the kind of exposures that you could be thinking about. And when you're developing a study, you could be thinking about out of the box type of exposures. So they don't have to be radiation exposure or treatment exposure or some other kind of exposure or intervention. But here we're looking at a simple slippery floor compared to a non-slippery floor, and you are looking at the number of falls a person has. Now, if this was a case control study, how would you do that? Okay, so you would get a case, number of people who've actually reported to their doctors, GP surgery, or they've gone to A&E with a fractured hip or a broken leg, and they've presented themselves through an adverse event. And so you have to kind of backtrace that and say, oh, what happened? They say, well, I slipped on a slippery floor. And, so say, okay, when did that happen? And you basically recollect their histories. And then you say if it's a lady of a particular age, then you need another lady who didn't fall, had a similar kind of thing. So you have to match exactly the similar age, similar characteristics of that person to the control person, and you have to do it similarly for the ethnicity. So somebody from an ethnic minority coming along, having the same experience, would then basically you would need to match again, find another person from an ethnic minority. So it gets prohibitively difficult to keep on matching like that, and costly and time consuming. But I hope you get the message in terms of the matching and the kind of design ideas involved in case controls, which are rampant. I mean, every group has more or less done it, and I've done enough studies of case controls over my career. So, but this is what is involved, because you have an observational data set, and we kind of interrogate the observational data set as best as we can, and then we try to eliminate the confounders. We say, well, you know what, age is a confounder here, because you could be an elderly person, you're more likely to fall if you're frail. You could have a young person here, but the other key point, which we can't actually put into case control studies, is what happens prior to the fall. Right, what is the history just prior to the falls? So, for instance, a person could have fallen because just prior to them walking into a slippery floor, it was raining, so their footwear was compromised, and so they end up slipping. So, but this is in the case control series, we can actually have a period which is pre-event, and that can actually allude to the fact that other things are happening that we may need to investigate. Whereas in the case control, you won't have that liberty, because you're matching one-to-one, and you're just interested in an event, falls or no falls usually, and so this is where the power of self-control case series lies, is that we actually just use a single individual, but we break up the periods of exposure to baseline. So a baseline is when, say, supposing they were just walking on the street, which is non-slippery most of the time, and the exposure is a slippery floor. So they're going to a building, or it's snowed, or different scenarios could represent there. But it's basically we're splitting up the person's history of walking into different periods. And that's where the complications lie, is do you have enough data to do that? Have you been capturing the data at the relevant time periods? And so luckily, some of this data is already collected in many areas. So it kind of speeds up your thinking. It helps you. Like, for instance, I'm going to present an example after this, but the complication of the self-control case series lies in the researcher's ability to actually dissect the data in different periods, and that is not easily done, as said, because things like routinely collected data, I don't know, data on childhood diseases, is there. So some of the earlier papers looked at I don't know, meningitis, or things that the GPs and other surveillance centers were actually accessing and having great amount of data. Then those things we don't have to spend much money on. But if we were to devise a new study where there isn't any available data, so we would have to think about this in actually capturing individual histories of the individuals that you want to do your analysis on. So I'll move on to the next slide. So as an example, I'm gonna talk through the published paper we had in Vaccine on, because what we did initially was we did a case control analysis. So we had quite a large sample size for this cohort, and this was a CPRD data set. So the paper is attached, for you all to go through. So I won't go too much into the statistical details of it, because I think the point here is to stress that there is an alternative paradigm of thinking about your research, and just looking at cases only and how you would do that. So basically that's what I've focused on today's talk. And the other very important part of it is how you would go around restructuring the data you already have. So it's basically, now, as statisticians, we're used to looking at data both in long view and short view. So in other words, you can look at it in Excel with thousands and thousands of fields going across, or you could spin that on its head, or you got thousands and thousands of fields going down, basically. So in either way, it's different ways of structuring the data on getting out the different periods you need. How do you identify each of these periods of interest, and can you do that? Are there any people, I mean, do a lot of people drop out? So you need to look at the censoring and look at the gaps. So any missing datas, are there lots of missing data, or are there some data that is quite useful, but then it goes missing later on, because that would influence that. So there's lots of data techie things that needs to be done, but the good thing is you don't need a lot of data. And so for the flu vaccination, we had the seasonal vaccinations, all the records. And then the other thing we did was we included this pre-vaccination period. So this pre-vaccination period is when they have nothing. They have none of the participants are actually vaccinated, but it's a couple of weeks before the pre-vaccination period. But we want to know is actually what is happening just before, just to see if they're elderly in care homes or even at home, and they could be getting vaccination outside the usual paths, the GPs and what have you. So that was just to see that if there are any surprises. And so a bit of statistics here. We use a Poisson, conditional Poisson distribution for these rare events. But another thing I'd like to mention here is that the assumption for the self-controlled case series is that you do the analyses over a period that the participant it doesn't change much. So in other words, if you've got age in there and you do it over 20 years, and of course the person's become frail, they've got multi-morbidities, that they're not the same person that you started off with. And so the assumption here is do it over a shorter period, maybe 5 years max, or something like that. And then the assumption is the person hasn't changed drastically. They're more or less the same. They're health-wise the same. They haven't become frailer. They haven't increased on their medications and what have you. So it's quite an assumption, but it's actually worked for the studies that I've done and the studies that I've been involved in. And so that would be one of the things that you have to bear in mind. And so now I'm just going to show you the schematic of the flu study that I did. Basically, we have a pre-start period. You have the vaccination for the very first vaccination date, and also basically the index date. So the index date here is the date they have this adverse event. So in my fictitious example, this will be a fall. But in this flu study, it's a stroke event, the very first stroke event as recorded by the GP. And then there's an end of observation period. So, of course, they could have had more than one event, but the index date is the very first event of stroke. And so the other technicalities of modeling this self-controlled case series method is actually splitting up the data into days of pre-vaccination, post-vaccination, 1 to 3 days, 4 to 7, 8 to 14, and you go to 180 days, so which is way beyond probably the lifetime of the vaccinations. The vaccines last, they probably last maximum about 3 months, 90 days. But we should see this. We should see this in the data as well. So the exposure period is when they have the vaccination. Okay. And so this was our the results of the study. So within the Poisson regression model, you get these the measurements that you get are called IRRs, so incident rate ratios rather than odds ratio, because you're not measuring the odds here. And you don't forget, we're just using a single person's journey. And there's lots of people in this study, so we just sum them all up in that. So in total, we had basically something like, or it says at the baseline was about 10,000 people and so the risk per year or time at risk in terms of years was 53,000. So it's quite a large risk period in there as well. And so what you can see here, incidentally, is that in the pre-vaccination interval, the first 14 days before the vaccination, the IRRs are 0.55. Now, that is really interesting because they haven't been vaccinated, yet the people just before are showing some kind of protective but some sort of protection is being conferred there, and then after the post-vaccination, you see it's shot to 0.45, and then it's gone to 0.64, and then it's gone to the actual days, because the vaccination actually takes 14 days to be active. So so up to before 14 days of post-vaccination, you just increasing your immunity. So the actual figure to take away from this is that 0.7. So actually, this is really, really interesting that 14 days after being vaccinated, you are 30%, nearly 30% more likely to have a less of an adverse event, and the adverse event here being stroke. So having a vaccination is protective against a stroke event, which is really really interesting, and this then complements our case control study, and in the case controls we found 24% protection. So this has shown a little bit higher protection, and in a way, I believe this result just as much as I believe the case control study, but because here each individual is actually controlling for themselves, and so as I mentioned, there are a plethora of variables that you could include in order to mitigate all the different types of control biases and things. And but some of them we probably wouldn't even think of. But in here, even the ones which we haven't thought of, are included. Okay, so the person's life history is automatically included because they're the same person that you're comparing against into the different periods. And so with this model, we also adjusted for seasonality. And so, some people having vaccinations within the season, some of them having a little bit late, and things like that. But it was really refreshing to actually to see this confirm our other study. And how am I doing for time? Okay, so.
And I think you're okay for another 5 minutes if you'd like to do
Yeah,
that.
sure. Yes, sure. Okay, so the other study is bisphosphonates. And this study was, I think about 5 years ago, we did the case control for this. And it's basically looking at an alternative as prescription for people with osteoporosis. And we wanted to know if bisphosphonates was safe to prescribe or not, actually. And because if you are prescribed calcium and vitamin D, you are prone in the long run to actually suffer a stroke or some adverse event, cardiovascular event. And so we had the data already, but the issue with this was that there are different types of bisphosphonates, similar to the vaccination, as there are different types of vaccinations. But in this case, there are different, what they call half-lives. So you take a bisphosphonate, some of them will stay days, others will stay months, and there are 4 different types of bisphosphonates, and they're basically used in few cases, but they're not. It's not normal practice for GPs to prescribe that. So we basically got the data for that, and we did a very similar kind of analysis to the vaccination one. And so the first date of bisphosphonate prescription is that's your observational start period, and then your end of the period is how long you stay within your GP practice. So basically, we wanted to include everyone who stayed at least 5 years within the GP practice. Similarly with the vaccination study, and the index date is the first date of stroke. And so this was a little bit technical in the sense of the half-lives and the washout period. So you have to wait within the exposure period another 2 and a bit weeks, just to make sure that now the bisphosphonate has actually completely cleared out of the body. So then you can stop the exposure period and then wait until they're prescribed the next one. And so we basically got a very similar result, but in this case, it wasn't statistically significant, but it's 0.94 means there is 6%, say if it was significant, then 6%. Sorry, yes, it's a 6% in favor of actually bisphosphonates being good for you as protective rather than detrimentals. But so this was a really good finding, but it's a negative finding, so it's difficult to get this published. But there are no associations between the risk of stroke and bisphosphonate treatment, so it's safer alternative to calcium and vitamin D. And so that brings me end of my talk, and I'd just like to thank my colleagues who worked with me on these projects. So Nero, Carol, Anna, Simon, John Williams, and Samira, Steve, and Paul. Thank you very much.
Thanks ever so much, Zahid. That was really good, and thank you for keeping to time as well. I'm going to stop the recording now, and that means that we will then be moving over into Q&A.